So with that, I want to bring in the other speakers of IASIC, Dr. Eric Volk, Dr. Ken Finley, and Dr. Catherine Henley. And we're going to talk about cannabis and public health. And Dr. Volk, if you come on right now, let me know you're on and I'll advance the slides for you.
Go. All righty, our video should be starting. I'm Dr. Eric Voth. I know some of you and have been working in this area for well over 40 years. I was an internal medicine, pain and addiction medicine by training, spent 10 years running a chemical dependence unit, and have literally been involved with several international organizations since the early 1980s. What we've seen that has really changed, though, over the past 40 years is what is on the market. The percentage of THC, now we've gone from what was a problem drug to now a critically problem drug with psychotic episodes, et cetera. So about 3 years ago, those of us that are speaking pulled together and decided we had to put together a physician-based organization that was absolutely on top of the research and that could serve as a resource, because we saw issues like Sanjay Gupta, who regularly gets on TV espousing all these wonderful effects of cannabis without really understanding the difference between the recreational, the truly medical and appropriate medication, which I'm going to spend a little bit of time talking about. Next slide. The other thing that we have really spent a significant amount of time is trying to go through the misinformation, trying to counter it, because it's very much to the benefit of the cannabis industry to have marijuana to be perceived as an innocent drug, no big deal, bury the realities. But there is a lot of research out there that we put out and make sure on our website that we're really educating people and disseminating the information. I want to highlight the fact, and I want to say this with absolute emphasis, there is an extremely well-organized cannabis industry, international cannabis industry, extremely powerful, influencing many, if not all states, and trying to come in the back door towards legalization. One of the journals out there called the Cannabis Law Journal advances itself by saying it represents over 200 of the best attorneys on cannabis. Well, let me tell you, that's pretty overwhelming when we look at what is happening internationally. So their intent is essentially to minimize the harms, to overstate benefits, which are actually not proven in the medical literature and good real medical research, and then to advance dangerous products, which we'll be talking much more about. When I was a kid, quote unquote, which is many years ago, the average leaf marijuana was pretty much ditchweed, 3 or 4% THC, and people still had trouble with it. When I was running a chemical dependence unit, it was a little bit more significant, but it was neck and neck with alcohol addiction. And now we're seeing preparations like the leaf marijuana preparations of easily 30% THC concentrations, vapes, oils pushing 80, 90% THC, which is frankly toxic. And one area that I want to really zero in on for a moment is cannabis-induced psychotic episodes. One of the hallmarks that we're beginning to see, and the research is early, but I think it's going to be very clearly pan out, is violent psychotic episodes with these significantly high THC contents. One of the first things that caught my eye several years ago now was when the Navy SEAL Chris Kyle was killed by a young man he was trying to help who had PTSD, but was a heavy marijuana smoker. And that individual got psychotic the night before, and when they went out to fire firearms and spend time together, he killed Chris Kyle, and one of the Navy SEALs. And that immediately got my attention. What happened here? Did this gentle, simple, music-loving drug marijuana turn into something different? And indeed, it had. And that's where we really need to focus a lot of our attention. Next slide, please. So our goal is to educate physicians. That was our first step, but we're beginning to see that we must be educating the public. They need to understand what marijuana use is, what it's impacting, and we need to really seek appropriate national and international public policy, both medical and public policy. Please take note of our links. If you go to our library, there's a scat of information on marijuana that you just really, I don't think we'll see anywhere else unless it were Library of Congress that you really dug through. Next slide. These are some of the things that IASIC has gotten behind in advertisements, for instance. We put doctor's warrant on cannabis, very simple statement. We went to a little bit more significant statement and tried to get IASIC noticed and out there. Next slide. This really goes through some serious health issues that we're seeing with marijuana. Certainly the ER visits and the psychotic episodes. Next slide. This was one of the shining stars that we really liked because it caught a lot of eyes. It angered a lot of the marijuana industry, rightfully. I think that's great because they need to take a look at their own doorstep and see what's going on really across international boundaries. Next slide. Now, what I'm going to focus on is what we'll call the standards for the use of medicinal or recreational marijuana, because really, if you look at medicine alone, there is always a set of standards that backs various medications or interventions or procedures that is justified by research and outcomes. And when you look at marijuana, it simply does not meet those. And we need to hold this standard high because we hold that standard high for all other medications, procedures, etc. Next slide. So the standard of care, believe it or not, there's not really a just written standard of care that physicians need to yield to and to always incorporate. But this is a legal definition that if a physician was to be sued, this would be the first line that would be presented is, does this qualified practitioner practice in a way that is same or similar to the other physicians in the area and must have the guiding principle of first, do no harm, primum non nocere. Next slide, please. So what are the basic elements? And now I'm talking about medicine. You go into a doctor's office with a complex complaint. Let's say it's pain. That doctor needs to be reviewing the diagnosis. I mean, do you really have pain, or are you just there to get opiates? What is your medical history? When did it start? How did it start? How did it affect you? What medications made any difference? And you will not find any of that in most of the marijuana dealerships. Just simply don't do medical exams or history exams or outcome exams. The recommendations come from either physicians, nurse practitioners, or those that are hopefully licensed in some manner in most states. But then I go a step further. Do a physical exam. What symptoms are they having? Is the physical exam consistent with those symptoms? Now let's talk about diagnostic studies. Oh, my leg hurts so much. My knee hurts so much. There are a number of laboratories, testing, drug testing, radiographic scans, et cetera. And why do I say drug testing? Because if you have someone that's there just to get opiates or just to get marijuana, you're going to see that show up in drug testing urine tests. So then you may try opiates, you may try marijuana or some THC preparation. And if you do that, the first thing you're going to do as a provider is to figure out a dose. You don't just hand them an opiate script that says opiates. Well, how many do I take? What dose do I take? How often can I take it? When should I be concerned about it? What are the overdose symptoms? And that's another responsibility of providers that must be done to meet standards of care. That is, warn the patient of potential complications. And that may be verbal, but in our society, it's usually written. And then you've got to monitor it. When we've looked at this, and we haven't as systematically as we might, most of the people that got recommendations for marijuana never get monitored. They don't get a follow-up appointment. Many states don't even have a required follow-up appointment. So monitoring goes to the wind. Next slide, please. In Kansas, the marijuana lobby has just been beating on the legislature to try to get marijuana passed. And I'm very happy to say that I've stood in the way of this for about the last 30 years. Our friends with IASIC came and testified. But here's one of the places that they're going. Instead of maybe a single diagnosis like severe unresponsive pain, they have listed 21 medical conditions that absolutely lack any kind of solid science that cannabis would be useful for. And then they have a tagline, as well as any other debilitating condition. Now, admittedly, it's Kansas, and we don't have medical marijuana, and we don't have legal marijuana, but this is what the marijuana industry is trying to push here. Next slide. So let's also talk about THC concentrations. You've heard this mentioned several times now, but it's fundamental, because if you look at legal THC in the drug Marinol, typically those are about 5 to 10 milligrams, and the highest doses recommended are maybe 20 milligrams. There's not a total consensus on that, but ballpark. So let's just say that you have a leaf marijuana that's 10% THC. Most joints are about a gram, about 1,000 milligrams. So 10% would mean 100 milligrams of THC delivered. But now let's talk about a lot of the leaf marijuana that's out there being in the 20 to 30 to 40% range. Now you're talking about delivering 300 milligrams of THC, or worse yet, the vapes and the oils ranging from 70 to 90%, where a gram is delivering 700 to 900 milligrams of THC. It is no wonder that you're seeing psychotic episodes from this. And of anything we need to pay close attention to, this would be it. Next slide. Now, one of the things that, as far as a product liability that has to happen, when you go buy a medication over the counter, you can be very certain that it's not going to contain these fungi: Aspergillus, Penicillium, Fusarium oxysporum, E. coli, Salmonella bacteria, Clostridium bacteria, and a whole host of heavy metals. This is proving, yes, I have a carefully created substance that doesn't have toxic contaminants with it. That is not the case, certainly with leaf marijuana, and certainly metals with the very highly potent forms are a problem. Go ahead and slide. And these are some of the heavy metals that have been identified in both cannabis plant and the oils. It's kind of ironic because marijuana does a great job of absorbing toxic heavy metals out of soil. But then again, if it's absorbing those and you're smoking it, guess where those metals are going, of course, into your system. Next slide. Now, as far as product liability, if you went and bought a bottle of Tylenol and you get that, open it up, there is usually an insert, and usually on the outside of the container, clear information that talks about the dose. Are there contaminants, or is it pure? There are warnings. Don't take more than 4,000 milligrams. Be aware if you take it with other medications. And then there's another element to the liability, which is direct injury. So if someone smokes and let's say their child becomes psychotic, or their child becomes psychotic and commits suicide, that is direct injury. There's clear evidence now about child abuse and neglect, motor vehicle accidents, and the opioid use overdose situation. Next slide. I'm trying not to hurry too much, but I want to leave lots of time for my colleagues because they've got a whole host of things to cover. So in summary, what my basic message is, if marijuana were to be used for medicinal purposes, there's a whole host of tests and requirements that must take place, not the least of which getting control of the amount of THC that's delivered in pure forms. And really, if you think about it, there's no compelling reason, if there is a legitimate medical indication, to go beyond Marinol, which is a prescription pill of THC. There's really no reason for that. I hope, and I'm going to be participating with some legal interventions to go after product liability, to go after physicians and other recommending medical providers who cause injury, who are not careful, who are not warning patients, and really try to get some serious impact to these people that are just willy-nilly, tossing marijuana around. And do please pay attention to the international picture. There is a huge, huge marijuana movement out there that does not have your well-being in mind. Thank you.
And now, Dr. Finn.
Can you hear me and see me okay, Renee?
Yes. Yeah, you're good.
Okay, I have a lot of ground to cover. In interest of time, we'll try to be fairly efficient. Just a background on me, I've been a practicing pain medicine physician in Colorado for nearly 30 years. I served on the Governor's Task Force Amendment 64 in Colorado when we legalized for recreational purposes on the Consumer Safety and Social Issues Work Group. I also served on our state's Medical Marijuana Scientific Advisory Council, edited a medical textbook, and helped this wonderful group of physicians found IASIC, which is now a member of the NGO, Vienna NGO Committee on Drugs that Dr. Lev covered. Lots to share. Next slide. I kind of want to go, we don't have time to get into some of the public health implications and implications across multiple organ systems, but I'm more than happy to answer any questions, and our slides will be available, and I think our emails will be provided as well. Next slide. It's important to understand that from a scientific and molecular level, things like dronabinol that Dr. Voth had covered, the natural THC or tetrahydrocannabinol, and natural CBD or cannabidiol all look very similar around the 7 o'clock position. There's a little bit of a difference in the molecular makeup of these cannabinoids. Next slide. But that's what they are. As a pain physician, this can be a very difficult and frustrating patient population to take care with, but it can be very rewarding at the same time. Next slide. This is a very important slide to understand what the difference is between cannabis-based medications and medical cannabis, because they are very different. Cannabis-based medications are standardized, defined content. Examples are things like Dr. Voth had discussed dronabinol, which is semi-synthetic, and Epidiolex, which is natural FDA-approved CBD for a very narrow spectrum of pediatric seizures, and Sativex or nabiximols that is not available in the United States. Medical cannabis, on the other hand, are just plant material, the flowers, the buds, leaves, extracts that are reported for medical purposes. And Dr. Voth had outlined some of the product integrity concerns with dispensary marijuana, which hasn't been effectively studied as a medicine. Next slide. But why do people see their doctor? They go for hypertension, obesity, asthma, diabetes, et cetera. But I've been following the National Ambulatory Care Survey for many years, and I think COVID backed up some of the data because it's a massive amount of data. But the things that are not, seen in the top 20 reasons, things like back pain, cancer, seizure, headache, et cetera, are not even the top 20 reasons why people even go to the doctor. Knee pain is the only pain diagnosis that's in the top 20 reasons people actually go to the doctor. Probably related to osteoarthritis of the knee. Next slide. I want to I don't want to get too sciencey on this, but it's important to understand that there's a very tight, intricate relationship between the cannabinoid and opioid system. They belong to the same kind of receptors that are found in the body. Next slide. They're found together at nerve endings. They also co-localize in the nerves that modulate pain pathways and things like, and they have same pharmacologic profiles, which does include, from a basic science perspective, what's called anti-nociception or pain relief. And naloxone, which is the opioid antidote, has been shown to have impacts on the endocannabinoid system in several animal models. Next slide. But why do people go use marijuana? They typically turn to pain. This is a nice review of all of the reviews of the reasons people are seeking pain. Next slide. Chronic pain is a problem. We are having an increase in chronic pain. Interestingly, one of the platforms to legalize is going to help our drug epidemic. And in Colorado, which I'll get to, the most common reason, and in other states, why people are given a medical marijuana recommendation is for pain. But despite that, our chronic pain problem is worsening over time and is very costly. It's a huge drain on the healthcare system. Next slide. This was a very interesting paper that just came out last month. The association between medical and recreational cannabis laws with cannabis use disorder were greater in patients with chronic pain than in patients without chronic pain. There's a journal called Lancet. I mean, it makes sense when you expand marijuana programs, whether medical or recreational, more people are going to use. And when more people use, they develop what's called a use disorder. And this was the graphic showing the relationship between having no medical or recreational laws and the prevalence of cannabis use disorder. And clearly, those states that have higher expanded programs have higher numbers of people with cannabis use disorder. Next slide. Next slide. Back in time, over time, the platform is that it's going to help our drug problem. I think the opioid epidemic was front and center. Fentanyl has spun off into its own beast, I thought, but there actually is a relationship between our fentanyl crisis and marijuana, which I'll get to. But over time, the data, the medical literature is very clear that marijuana does not reduce severity of pain and actually does not exert any type of opioid sparing effect. And actually, Chelsea Shover and Keith Humphreys from Stanford actually showed that states passing medical cannabis laws have a nearly 23% increase in overdose deaths. Next slide. Other data shows there's no protective relationship between medical cannabis laws and opioid overdoses. It kind of goes against the grain of a protective effect of medical cannabis laws on opioid overdoses. Next slide. Having a medical marijuana card, actually you have a higher incidence and severity of cannabis use disorder and no impact on your pain. And as a side note, I was a former registered medical marijuana patient in the state of Colorado. Full disclosure, I don't use. However, I was curious to see what it took to get a medical marijuana recommendation in Colorado. And without any fanfare, no exam, no medical record review, no review of imaging, because I didn't make anything up. I was approved for severe pain in 60 seconds. There was no question on what level of pain I normally have, which on a day-to-day basis is about 0 to 2, because I need my knees replaced because I was a collegiate soccer athlete and has had multiple surgeries. But it was very easy to obtain a medical marijuana recommendation in Colorado. And I got my renewal a year later with no fanfare. It was pretty easy. Next slide. Here in the state of Colorado, one provider made between 7,000 and 8,000 medical marijuana recommendations. That kind of translates into one patient every 20 minutes. This kind of underscores what Dr. Voth was talking about in terms of standardization of care. When you have 3 providers making 25% of all the recommendations across the state, between 5,000 and 8,000 recommendations in 1 year, they're not evaluating these patients. They are not doing a comprehensive history and physical examination. They're not reviewing medications. They're not discussing drug interactions that can potentially be harmful or even deadly. So it kind of underscores the ruse of some of these state medical marijuana programs. Next slide. In Washington, D.C., you don't even need a physician supervision to be a quote patient. You can go to a kiosk, you say, I have headaches or pain, and you can get your medical marijuana recommendation without physician supervision, which I don't know how you can be called a patient when you're not being followed by a medical provider. Next slide. Again, here's a nice paper that showed that medical marijuana users were using medically only 20% of the time and recreationally nearly 80% of the time. So are they simply medicinalizing the recreational use? It's kind of been my experience in my own pain practice when I ask patients about whether or not marijuana was helping their pain. The vast majority tell me it does not help. It's completely anecdotal, but it's very consistent with the medical literature, and it's very consistent with my colleagues in the pain organizations I'm involved with, which include the American Board of Pain Medicine, the Colorado Pain Society, and the Texas Pain Society, which I'm very active in. Next slide. You need a lot of marijuana in your system to demonstrate any type of pain reduction. Again, I stated earlier that from a molecular and basic science perspective, there is evidence that marijuana and cannabinoids may have an analgesic or pain relieving effect, but it doesn't translate into the real world when you're using dispensary marijuana. However, if you look at the levels of THC in your blood that are required for any type of pain relief, you need between like 18 and 30 nanograms per ml. In Colorado, although I don't believe that there's a per se limit on impairment, driving impairment, in the state of Colorado, we have 5 nanograms per ml is considered driving impaired, although per se limits are very difficult to determine. So you do need a lot of marijuana in your system to have any impact on subjective reports of pain relief. Next slide. And this data was supported by another paper from earlier just a few months ago that's very similar to a phenomena we see in the world of opioids. Is called opioid induced hyperalgesia, when the use of the substance actually worsens your pain over time by reducing your tolerance to pain. And we see that both in opioid and as well as in cannabis. Next slide. Just a few months ago, there's been no effect between placebo and active treatment of THC or CBD alone or in combination for one of the more commonly studied pain syndromes of neuropathic or nerve-related pain or as spasticity that is associated with multiple sclerosis or spinal cord injury. So the data just isn't there that is very effective. Next slide. So next slide. I want to really highlight again this relationship between opioids and cannabinoids. The Youth Risk Behavior Survey from a couple of years ago showed that the #1 risk factor for an adolescent to misuse opioids is having ever used marijuana in their lifetime. So again, remember this particular data point. And that was followed up by other data from NIH and JAMA Pediatrics that after 3 years of first trying marijuana compared to opioids, marijuana has a higher percentage of addiction. And as a pain physician, I was very surprised to see this data. And then Wadaker's study from a few years ago showed that in adults misusing opioids, the predominant predictor is having used marijuana before the age of 18. And they looked at a bunch of different things with other illicits, tobacco, alcohol use, et cetera. But the predominant predictor of opioid misuse in the adult is having used marijuana before the age of 18. Next slide. Olson's study showed, again, cannabis use increasing your risk of opioid use disorder or misusing opioids. The driving data with National Roadside Survey and the FARS data show that drivers testing positive for marijuana are more likely to test positive for prescription opioids. Again, this tight interrelationship between cannabinoids and opioids. Next slide. A large study from National Survey of Drug Use and Health, consistent with prior data, past year marijuana use significantly increased odds of reporting opioid dependence and prior year non-medical use of opioids. Next slide. Other national and international organizations, like the International Association for the Study of Pain, which is the planet's largest pain organization, do not endorse the use of cannabis or cannabinoids for pain relief. That was also followed by the Faculty of Pain Medicine from ANZA, because the research is very low quality. And this is really pertaining to dispensary cannabis, which is what people are actually using. Next slide. Other organizations, the Australian Pain Society, New Zealand Pain Society, next slide. British Pain Society, next slide. European Pain Federation. The thing I liked about them, it was the first pain organization to address, for lack of a better term, a black box warning about not using opioids and benzodiazepines with cannabis. And also was the first pain organization to address potency, which I don't have time to go into. I think we have a very good speaker talking about that later, Dr. Libby Stout. But they didn't recommend anything more than 12.5 THC content. And in Colorado, the average smoke flower is about 20%, concentrates about 50-60%, and then the world of dabs and waxes and shatter are pushing 95, sometimes claiming 100% THC, which doesn't look like a plant anyways. Next slide. National Institute of Healthcare and Healthcare and Excellence in the UK doesn't recommend using cannabis for pain. Next slide. I want to cover very briefly our overdoses in Colorado by county. Next slide. This was just on the cusp of legalization. I live in El Paso County. Again, the platform to legalize is going to help our drug problem. Over 80% of the marijuana recommendations in the state of Colorado are for pain. And we're going to go back to 2002, just shortly after we implemented for medical marijuana use. And this is what happened to our drug overdose death rates. Next slide. 05, next slide. 08, next slide. 11, next slide. 14. It hasn't gotten better. And in just like other states that have gone down this road, our drug crisis is worsening despite more states legalizing for medical purposes, knowing that the most common reason is for pain, and our drug overdoses are simply worsening, and it's not helping our drug crisis. Next slide. Prescriptions are going down, but our drug deaths are going up. This is 21 data. Next slide. The 22 data, there was over 111,000 drug overdoses in the year prior. So it is worsening. Next slide. Drug overdoses went up during the pandemic, and there is a relationship. The marijuana use also went up during the pandemic. So there's definitely a strong correlation. Next slide. Here in Colorado, you look back in 2001 when we implemented our medical marijuana programs, and it lay dormant for many years just because there was no infrastructure. Physicians were reluctant to recommend. Patients didn't have dispensaries to go to. But after a lot of politicking in 2009, we had, for lack of a better term, de facto legalization, where the marijuana dispensaries opened up across the state. To even this day, the dispensaries, both medical and recreational, outnumber the number of Starbucks and McDonald's combined in the state. And that was 2019 data. Next slide. 2020 data, it's gotten worse. And interestingly, it looks like the COVID curve, fentanyl starting to take off at this point in Colorado and across the country. Next slide. 21, it's still getting worse. And they had to compress, the CDPHE had to compress their graphic because of our drug crisis worsening. Next slide. The 22 data, next slide. And maybe we're reaching a point, maybe I'm hoping we're reaching a point where we've had a pinnacle, but a 1 year to comparison does not equal trend. It's just like the stock market. There's ups and downs, but the overall trend is still ongoing worsening. And interestingly, our heroin deaths are going down, despite as widely available and cheap and readily accessible it is. I think fentanyl is the new heroin, but we've also seen overdoses in stimulants like cocaine and methamphetamine. All these drugs play well in the sandbox together. And this is very consistent with other state data. Next slide. We talked about these playing well in the sandbox. This came out just a few months ago. Marijuana and hallucinogen use at historic highs among adults. And these are touted as medications. So, we have to do the research and put the cart behind the horse before we open the door to the public on this. Next slide. Canada is having the same problem. Their drug overdoses are going up. Next slide. We published a paper about a year and a half ago showing, despite the fact that marijuana is supposed to help reduce our opioid dependence and mortality, opioid death rates have increased more where marijuana was legalized, particularly fentanyl death rates in legal states. Next slide. Here's the graphic for that. You can see that the green line is in marijuana legalizing states and their fentanyl death rate compared to the black line, which are non-legalizing marijuana states at the time, both medical and recreational. There's a significant gap between the fentanyl death rate and states that are legalizing for both medical and recreational purposes. Next slide. Just came out earlier this year. Legal marijuana, particularly when available through dispensaries, shows higher opioid mortality. Again, this link between opioids and cannabinoids. Next slide. We just this is not peer reviewed. This is just preliminary data showing during the pandemic, jurisdictions that had recreational legalization prior to 2019 had greater increases in overall opioid and fentanyl death rates than jurisdictions with medical only legalization. So when you have expansion into the recreational world, particularly during the pandemic, we had increases in opioid and fentanyl death rates. Next slide. Marijuana is no better than placebo. This came out from JAMA about a year ago. Next slide. Cannabis laws and impacts on pain. Again, there's no impact on opioid prescribing, non-opioid prescribing, so anti-inflammatories, et cetera, or even interventional pain procedures. So it's just not helping our management of pain, and it's not helping our drug crisis. Next slide. This was a nice study that came out a few months ago looking at the military patient population. The body of evidence really doesn't support the use of cannabis or cannabinoids for pain or PTSD in that particular population. This was a review of 36 randomized controlled trials looking at cannabinoids for pain management or PTSD. Basically, no benefit. Next slide. Perioperative use, I published a paper showing you got to be careful and evaluate these patients prior to surgery. Next slide. This was followed by ASRA, the American Society of Regional Anesthesia. They recommend screening patients for surgery because there's potential negative implications in terms of perioperative pain control, opioid use, et cetera, and healthcare costs. Next slide. Perioperative complications. Cannabis use disorder has higher patient morbidity, mortality with major elective inpatient non-cardiac surgery. Next slide. Marijuana use and prolonged opioid use in adolescents and young adults. It's just not helping these younger people use opioids post-operatively when they have legal access to medical marijuana. Next slide. Again, July of this year, current available use just does not support the use of cannabis, cannabidiol, other cannabinoids for the treatment of most conditions. And doctors aren't going to recommend crude cannabis as a medication because it hasn't met the definition of what a medication is, which we don't have time to get into. Next slide. So in summary, before we move on, there's currently no evidence, zero evidence supporting the use of dispensary marijuana for chronic non-cancer pain. There's no package insert for dispensary cannabis. I mean, whenever you go to the pharmacy, you get your prescriptions. There's a piece of paper that comes with it that ends up in the trash for most people, showing the risks, how to take the dosing requirements, maximum dose. There is nothing like that for dispensary cannabis when it's treated as medicine. There's no evidence of substituting opioids with dispensary marijuana. And actually, states with medical and recreational programs have higher opioid death overdoses than non-medical marijuana states. So any real benefit, because again, from a basic science and molecular perspective, it should help, but any real or perceived benefit is far outweighed and outstripped by current evidence. Next slide. It was the impetus to edit a medical textbook with 70 authors, 4 countries, 20 chapters, and a year and a half of my life I won't get back. However, I do have a much higher respect for people that do editing. It's very, very challenging. Next slide. And it was also the impetus for us to found our nonprofit. Next slide. And this is what I prefer to do before I come to the office is get a nice hour-and-a-half mountain bike ride. Here's in my backyard, not my literally backyard, but in Colorado Springs. I spend a lot of time in the mountains before I go to work, just for kind of set myself up for the day. All right, so I'm going to stop there and pass it back to Dr. Lev, and thank you for the opportunity and time. And again, our slideshow will be available and my email should be available.
Thank you, Dr. Finn. Dr. Antley, are you there? And also Dr. Finn is very active on X, Twitter. So if you keep up with him, you'll be keeping up with whatever's current on cannabis.
Yes, I'm on. Thank you. Thank you, Ken, and thank you, Ronit. It is my pleasure to be here today. I am a board certified anatomic and clinical pathologist. I'm a dermatopathologist as well. And for the last 10 years, I've been active at the level of the Vermont Medical Society as the state considered and subsequently legalized marijuana. I'm also one of the co-founders, and I currently serve as treasurer of IASIC. Next slide, please. So while cannabis impacts health in many ways, perhaps the most devastating is its link to psychosis. Lung cancer often kills its victims in their 50s and 60s, 10 to 20 years earlier than they normally would die. Severe mental illness attributed to cannabis smoking can devastate marijuana users' lives in their early 20s and impact an entire family for years. Unfortunately, folks who go on to develop cannabis-induced schizophrenia also die decades earlier than they otherwise would. Family members and loved ones of those suffering from psychosis, schizophrenia also experience increased morbidity. Next slide, please. Because it is unethical to give potentially harmful substances like nicotine or tobacco to human test subjects, decades ago, scientists drew on the Bradford Hill criteria to determine smoking causes cancer. They did this because we cannot ethically divide a kindergarten of similar kids into two groups and give one group tobacco and the other no tobacco to see if the tobacco using group in 20 or 40 years develops lung cancer, heart disease, or dies 10 years earlier than the other group. IASIC has many important researchers. Please go back one. Thank you. Including Sir Robin Murray of King's College London and Dr. Marta DeForti, together with these folks, together with many other important partners internationally, we have a greatly expanded understanding of the causal role of cannabis in severe mental illness, psychosis, and schizophrenia. At this point, the evidence goes far beyond association studies. We have randomized controlled studies, their genetic studies, and their complicated designs, which all strengthen the case for this causality. Neuroscientist Dr. Christine Miller, an advisory board member of IASIC, has written a formal, detailed analysis assembling the evidence that cannabis is a component cause of psychosis and schizophrenia using the Bradford Hill criteria. Her full article and analysis can be found on the IASIC website. Next slide, please. So evidence satisfying the Bradford Hill criteria that cannabis is a component cause of psychosis include, number one, nearly half of patients who present with cannabis-induced psychosis will convert to full-blown schizophrenia or bipolar disorder with psychosis. Number two, greater use of more potent products results in higher incidence of psychosis. Number three, the active ingredient in cannabis, THC, when given to randomized controlled normal volunteer patients can create psychotic symptoms during the clinical trial. Number four, the majority of patients who develop psychosis or schizophrenia using cannabis have no family history of schizophrenia. Number five, cannabis beats all other drugs of abuse in leading to psychosis or schizophrenia, even when compared to drugs like PCP, meth, or chronic alcoholism. Number six, in some cities, 30 to 50%, fully half of the patients who present to their doctor with first episode psychosis, a medical emergency, have in fact cannabis-induced psychosis, resulting from their regular use of just 10 to 15% THC. These severely affected and mentally impacted patients would be well, but for their use of cannabis. Next slide, please. There are new studies that are coming out all the time. This is an interesting article which came out in 2022, Association of Cannabis Potency with Mental Ill Health Addiction, a systematic review. They found overall the evidence suggests that the use of higher potency cannabis compared with the lower potency cannabis is associated with an increased risk of psychosis, and this risk is higher in people who use cannabis daily. Higher potency cannabis use has also been associated with an earlier onset of psychosis, more symptoms of psychosis, and an increased risk of relapse. The study found that use of higher potency cannabis was also consistently associated with increased risk of use disorder, recent cannabis use problems, and severity of cannabis dependence. To quote Sir Robin Murray, at this point, we can say no serious scientist continues to dispute that cannabis is a component cause of psychosis. Next slide, please. Cannabis-induced psychosis and schizophrenia can be devastating to a family. As a member of the board of IASIC, parents often call asking for information and guidance after a son or daughter begins to suffer from cannabis-induced psychosis or schizophrenia. Last year, a mom called to say her family had spent their entire retirement savings trying to treat their son's cannabis-induced illness. And yet today, he's still using. Tormented by voices and hallucinations and believing paranoid delusions, he's still suffering. And that family is still suffering. Because marijuana addiction and the diseases which result from its use, like schizophrenia, are so devastating and yet so difficult to treat using rehabs, medication, antipsychotics, or therapy, we are compelled to work together to educate and prevent. To do this best, we must engage public health experts and employ data-driven, scientifically proven prevention interventions. In 1964, when physicians and scientists finally linked smoking to cancer using the same criteria we are now using to link cannabis to psychosis, there was public outcry. People were angry at how they had been misled by folks who had been allowed to tell the public that smoking cigarettes was not harmful, even good for you. They asserted that cigarettes were good, was good for asthma, for example, and that nicotine was not addictive, as the head of the tobacco companies testified to Congress. As a result of this public outrage, and because some politicians were effective public health leaders on the issue, warning labels were required on packaging, advertising was banned on broadcast media, and an ongoing and annual review and report was ordered by the Committee on the Health Consequences of Smoking. We all know that when accurate disclosures were made and where effective prevention methods were employed, tobacco use decreased. Effective prevention is possible. Subsequently, the diseases and deaths due to tobacco also diminished. We have effective prevention interventions which work if enforced. When provinces allowed, sorry, next slide, please. Next slide, please. When provinces allowed edibles, we're going back one. When provinces allowed edibles and high THC concentrates, child poisonings in these provinces spiked. You can see on the slide, child poisonings did not spike in provinces like Quebec with THC caps of 30%, and also where no legal candy edibles were sold. Next slide, please. In Ontario, Canada, ED visits for adults and youth increased when more retail stores were allowed. Outlet concentration impacts poisoning rates. Next slide, please. Products appealing to children are illegal in Vermont, and this is the statute. Next slide, please. However, orange marijuana lollipops can be found and are sold legally in licensed stores in Vermont. But sorry, they're sold illegally, but they're sold in legally licensed stores in Vermont. Next slide, please. Our child marijuana poisoning rate has increased 1,375% according to the National Poison Control data. In Quebec, where THC concentration is limited and no candy edibles are allowed, the black market sale of these products did not increase, and children were protected from poisoning. Here are some examples of candy marijuana currently sold in legally licensed Vermont stores. Next slide, please. Next slide, please. Here's some more examples. Next slide, please. Next slide, please. So over the last decade, Vermont physicians have repeatedly warned of the risks of marijuana consumption and commercialization and child poisoning. And the Medical Society has made the following recommendation regarding marijuana labeling when we did decide to commercialize. Quote, warning. Cannabis THC may cause, number 1, psychosis, number 2, impaired driving, number 3, addiction, number 4, suicide attempt, number 5, uncontrolled vomiting, number 6, harm to fetus nursing babies. With an asterisk, psychosis and suicide attempt can occur in individuals with no previous history of psychosis or mental illness. Next slide, please. Unfortunately, in Vermont, the 31-word doctor's label was not adopted by the Cannabis Control Board. This warning label, which you see in this photograph, was approved by the Cannabis Control Board. It's over 100 words long, and it is inadequate by omission. It does not mention psychosis, suicidality, cannabis hyperemesis syndrome, and it's also illegible because it was allowed to be put in this tiny 6-point font. Next slide, please. Here we see the Vermont cannabis warning label is found hidden under the nutrition label, and this was also found in a legally licensed marijuana store in Vermont. Next slide, please. It is well known and has been demonstrated both in the United States and abroad that when correctly implemented, effective prevention methods have been shown to decrease addiction across substances. And here we have alcohol, tobacco, and marijuana. Reliably and consistently across cultures and socioeconomic groups. When systematically implemented in Iceland, these changes have also been associated with decreased crime, decreased rape and violence against women, as well as actually halved admissions for substance use disorder in the cohort of young men 20 to 25. Next slide, please. With cannabis, as with other drugs like tobacco and alcohol, effective prevention begins by countering the prevailing misperception of benignity and replacing it with a frank discussion and acknowledgement of the risks and harms, using accurate, proven scientific data and facts about the health and psychological consequences that can be seen with cannabis use. This presentation has been dedicated to Patty, a Vermont mother who lovingly and competently cared for her family member with cannabis use disorder and psychosis and eventually schizophrenia for decades, before she was suddenly overcome with unrelenting depression. Sadly, she succumbed to her suffering, jumping into the frozen Winooski River in December, now 6 years ago. Unfortunately, this story has a coda. Her son, while in treatment for his schizophrenia, but in a marijuana-triggered psychotic episode, had a mistaken belief that his nearly 80-year-old dad's cell phone was a threat. In response, the son attacked and assaulted his widowed father, seriously injuring him. Cannabis-induced psychosis impacts the individual as well as the family surrounding and supporting the person. Next slide, please. This is the Vermont Medical Society recommended warning labels once again. Next slide, please. And we have to ask at this point, has the time come to publicly acknowledge the risks and harms resulting from cannabis use and implement effective, enforced warnings and prevention measures in the United States? And that's all I have today. Thank you so much for your attention. That's my last slide.
All right, thank you so much, Dr. Antley, Dr. Finn, Dr. Voth. We will have this presentation, give it to the Western states. We're all happy to share all of our materials we want you to share and educate further. We have some time left. I'm going to go quickly through my slides so we have some time for questions. What's the state in California? California is the very first state to legalize marijuana medicinally in 1996 and 2016 in adult use. And since then, not one legislation has been passed about the harms or to prevent the harms, but not for lack of effort. Last year, we tried to do what Vermont did with warning labels. We have warning labels on everything, right? We have on your mattress, if you watch TV and there's flashing lights, there's warning labels. What our country believes in warning labels. Go to the supermarket, there's warning labels on everything. We just wanted some warning labels on cannabis products, and that got shot down. So that we thought, okay, what could we do next? You know, the government's not going to approve warning labels. What do they care about? Maybe people care about babies. We have data that's showing that the #1 poisoning of children, babies under the age of 5 is marijuana. And why in the world do we need Weedos that look like Cheetos and Sweet Tarts and all these candies? Who is that for? Do adult recreational news really need that candy? And as Director King said at the beginning, we have increasing incidents across the state, up and down, of children at school where they should be safe, going to the emergency department, 911. For cannabis. And you're going to hear later from Dr. Laub, these kids are not giggling. They are encephalopathic. They can end up in the ICU. They could end up in a ventilator. So we wanted to just protect children with the Cannabis Candy Protection Act. And what happened to that this year? Extremely disappointed. That got vetoed. Although we got it through, the governor vetoed it. So now other laws, this also was vetoed, but there's a strong movement to normalize, commercialize drug use, like I mentioned, across the state, across the country, across the world. And thankfully, this was vetoed for now to approve all psychedelics. We're seeing that in the emergency department, more cannabis lounges that got vetoed. And again, as an emergency department, every single shift, not one, I could say probably like more than one case of cannabis associated poisoning. Seeing that in the form of psychosis, suicidal ideation, cannabis hyperemesis syndrome, heart effects, lung effects, drug interactions, etc. Scromiting, my favorite word, because I was really frustrated one time when we did a press conference on cannabis hyperemesis syndrome. Nobody showed up but one reporter, and I went off script and said, scromiting is the hallmark sign of cannabis hyperemesis syndrome. And that went viral, and actually helps me explain to my patients when they're scromiting. You could hear it, an audible diagnosis. Drug interactions. Who think you could have internal bleeding? You could bleed to death from marijuana. How could that happen? Not from the marijuana itself, but if you have heart stents or you have atrial fibrillation and you're on blood thinners, use that plus marijuana, it makes your blood thinner. Also something that is not out there. If there's one thing you could get out of this lecture to share with your friends who think, oh, maybe I should use marijuana for my whatever it is, or I use that for my pain or just to help me sleep, check for drug interactions. You could do this yourself. Go to drugs.com, go to the little drug interaction checker, put in your blood pressure medicine, add in cannabis for marijuana or cannabidiol for CBD, and make sure they're not interactions. There are over 500 drug interactions with CBD and over 300 with THC or cannabis. I work in a trauma center. Sadly, we have cases of cannabis associated fatalities. I took care of recently a 21-year-old who's driving in the morning. I treated him for trauma because he crashed his car, but he killed a 54-year-old gentleman. He killed someone. He's going to have to live with that the rest of his life. Our library is out there for your use. We took this complicated medical jargon and put it in language that you could understand or anybody could understand. So I don't expect you to remember everything we said today. There's a lot of complications, but you could easily, at your dinner table, get out your cell phone, put in IASIC1.org, go to the medical library. And when you're trying to win an argument about violence or schizophrenia, just click on schizophrenia. There'll be the articles. You could make your point. And if you need the literature, you have that backing you up as well. So that is for your use. It's a great tool that we hope you share. Other resources, again, medical textbook. You could follow my podcast, High Truths on Drugs and Addiction. IASIC itself has free lectures on a regular basis from top experts from around the world. In addition to our library, we have guidance for other medical providers. We know people are using marijuana, but you should know about safety. Just like we did with opioids, we're doing that with cannabis. We're at the beginning of this, so it's painful to be ahead of the curve, but that information is out there. And with that, I have time now. Caught us up in times of time. I'm going to stop sharing. You could reach us through our website, IASIC1.org. Hopefully you could get these presentations from Western states, and we'll open it up to questions. I invite our panel members to get on camera. And we have a few minutes here for questions. Could start with my friend Ron Stark, who has a question about, well, what about cigarettes and tobacco? They don't have dosages. So whenever you have a really good question like that, like, hey, what about that? Why does that make sense? Why is it seems so concordant? I think you have to go back to the question, right? When it comes to medicine, if we call something a medicine, then it has to follow FDA guidance of what a medicine is, with risks and benefits and dosages. If we don't have that, then the FDA is no longer valid, and none of our medications that we prescribe for anything, for cancer or heart disease or anything, is worth anything if we don't have that product. So maybe you're asking, well, what about comparing it to alcohol or cigarettes. Again, alcohol and cigarettes have warning labels that we don't have for cannabis. And we have amazingly good standards for alcohol. If you buy a bottle of vodka anywhere in the world, you're not going to be afraid that it has methanol in it and make you go blind. There have been international standards on alcohol that we have nothing like when it comes to cannabis products. And I'm going to let my colleagues chime in now.
I'm going to chime in right there. The legal drugs we already have, like tobacco, like alcohol and opioids, which do make a lot of money for their respective industries. We know that there are societal impacts and costs associated with that. And a lot of the states that I work with across the country always talk about how much money they're going to make. And I point out the fact that these addiction for profit industries like alcohol and opioids and tobacco do make a lot of money. However, they do also create a huge societal cost. I mean, some of the data out of Colorado shows that for every dollar generated, it costs $4.50 to regulate. And I'm not sure I believe in that $4.50. I think that might be a little inflated, but it's certainly not a money maker at the end of the day. And I think a lot of our state leaders can't spell P&L or profit and loss because they always talk about money generating and fixing their budgetary problems. But when you have an addiction for profit predatory industry like marijuana, it's not going to be a money maker because there are going to be societal costs. I mean, Dr. Lev in her hospital and some of the papers I published show that just in Colorado alone, potentially between 2009 and 2014, the state lost $500 million just from marijuana-related healthcare costs. So that's just in the emergency department. And that doesn't take into account addiction treatment, law enforcement impacts, environmental impacts, where, in Colorado, for example, the marijuana industry creates more carbon emissions than its coal industry. So this is not a very green industry, number one. And it's certainly just simply another addiction for profit industry that is already costing our society in several ways. And Dr. Lev sees that every day. And my colleagues in emergency medicine have told me they see that every day as well. So I think it's important that we really approach this from a public health and safety perspective and a science-based perspective. So that's a long-winded answer to the topic.
I'd like to jump in also. What I've seen in a number of states is the phenomenal impact of the lobbyists. I mean, when all this stuff was going on in Kansas, the lobbyists were shoulder to shoulder with the lawmakers, just, coaching and goading and pushing. And there may be a place to, step in there. But the other side of it is our side, quote unquote, maybe needs to have more aggressive lobby on saving kids and do, things that really can push back on the marijuana lobby. But it's phenomenally powerful. It's not as good as the alcohol lobby. They're and tobacco lobby. They really have that figured out. But consider also, what do we have? 100,000 people die every year of tobacco. Isn't it 100,000? Yeah. 10 million alcoholics. I mean, those heavily lobbied industries don't seem to care. They keep pushing their stuff. And we're seeing it too right now.
And Eric, on a side note to that, in Colorado, nearly 1/2 of the lobbyists purposely hid their funders' marijuana affiliation. They use strategies to hide their marijuana funding. So their pockets are deep, and they use strategies to kind of hide this relationship between their lobby and marijuana businesses. So it's somewhat frightening that I'm sure if it's happening in Colorado, it's happening in other states.
There's a question out there about hemp-derived THC and Delta 8. I think before we answer the question, we should understand the definition. What is hemp? That's a political government definition, not a medical one. Congress defined hemp as less than 0.3% Delta 9 THC. In Europe, that definition is 0.3% delta 9 THC, and therein lies the problem, is the definition. But because Congress said hemp is less than 0.3% delta 9 THC, some clever people said, hey, that means delta 8 could be hemp and delta 10 could be hemp, and it unleashed all these legal products with the definition of hemp because the definition itself was a problem. Those drugs, delta 8, delta 10, were never studies, not in mice or rats. The first experiment on them are in humans and children. Our children, there are children who died of it. Yes, to answer your question, there are mental health issues. The problem with the hemp products have been presented to the FDA. The FDA issued a warning saying, we don't approve these products. They are hazardous. Keep them away from your children and pets. There have been calls to emergency departments and poison centers about the products, but we said, we're not going to solve this. Congress, you fix your messed up definition. And I think there's work on that.
There are a lot of loopholes in that isomerization and THC analogs that are legal in several states like Florida and Texas. You can buy delta 8 THC at a gas station or convenience store with no oversight in terms of product integrity, contamination, other cannabinoids that may be in it. I answered one question earlier that THCO, which is the O-acetate of delta 9, actually the O-acetate of delta 8 THC, which does come from federally legal hemp. THCO was weaponized by the US government in the 1940s as a chemical warfare agent. So they've known about these isomers and analogs for many, many years. You can actually go online and purchase THCO. And these are on industry websites. And if you look at the comments, they're very, very strong. I think THCO is reported to be 3 times stronger than delta 9 THC. It eroded dogs' muscle coordination a lot faster than traditional delta 9 THC. You have the HHCs and the THCPs that are even more strong than that, that are coming from federally legal hemp. Because they mass produce CBD and with chemical manipulation of the molecule can create these isomers and analogs that are potentially dangerous and can cause the similar effects as delta 9. So I think these loopholes need to be closed. We need to protect public health and safety. And I think that not only does the general public not know about this, I can tell you that most of our physician colleagues have absolutely no idea of these isomers that are readily available and what harm they could do. I think Dr. Lev mentioned there was a 4-year-old boy in Virginia that died from consuming his mother's delta 8 THC, and she was sentenced to prison for murder of her 4-year-old child. So these products are not safe, and I think we need to really sound the alarm and make sure these loopholes are closed and we protect our communities.
You know, one thing I'd want to add to this also, you know, if you look at these very violent psychotic episodes like that main character and some of these others, I'm incredibly suspicious that they didn't just go out and drink and get crazy, that there was something else going on. The guy's 40 years old. He had some, you know, social stuff going on, but then even having been in the military, goes psychotic and kills a bunch of people. I mean, and that is not uncommon when we keep hearing about these. And I'm wondering if there isn't a better way to somehow knock on the door of the psychotic, violent episodes and see if we can get a better systematic look at that. You know, I've called a couple of examiners, you know, saying, hey, are you running urine screens or tissue screens? And a lot of them say, no, it's too expensive. We don't have money for that. Well, it may be fundamental to what's going on. So.
All right, we have a lot of good questions. There's one about fentanyl and marijuana. We haven't had any in California, although there's people who may be using marijuana and that there's some fentanyl residual in their bong or something, but actual fentanyl in marijuana products we haven't found in California. There are other states where that has been found, to kind of answer Richard's questions. Please visit us at IASIC1.org. Come see our library, our webinars, our social media, our advertisements. We're there to help you as a group of physicians, and you're not alone. Sometimes it feels that way with the marijuana issue. You're on the right side, so please continue what you're doing. Thank you to my colleagues, and thank you, Haida and NMI, for this opportunity.